Hello, and welcome to a short presentation about the induction of general anesthesia. We are currently two second-year CRNA students with Gonzaga University completing our senior capstone project and wish to explore the efficacy of high-fidelity simulation training on student nurse anesthetists. We would like to first thank you for your time and assisting us in completing our project. The objectives of this presentation and simulation training are for all participants to perform an induction sequence for a general anesthetic, improve technical and non-technical skills, verbalize the rationale for the pharmacologic agents utilized. First and foremost, we need to define what exactly is general anesthesia. General anesthesia has been described as a combination of hypnosis, analgesia, and muscle relaxation. This is often referred to as the triad of general anesthesia. To put it another way, the components of general anesthesia include amnesia, analgesia, and akinesia. In other words, a lack of awareness, a lack of pain, and a lack of movement. So, moving on to the actual induction sequence. The goals of the induction sequence are to render the patient unconscious, blunt the sympathetic response to laryngoscopy, facilitate endotracheal intubation, and to maintain an anesthetized state. Next, some important considerations during the induction of general anesthesia. Consider patient positioning. Patient positioning is key to optimizing intubating conditions in the anesthesia induction sequence. Apply appropriate monitors and obtain baseline vital signs prior to the induction of anesthesia. Pre-oxygenation with 100% FiO2 prior to the induction of anesthesia. Prevention of corneal abrasions. Eye injury is a common occurrence, and taping the eyes prior to mask ventilation can help prevent this. Ensuring the ability to mask ventilate the patient prior to administering a paralytic drug. Following intubation, confirmation of endotracheal tube placement. This is achieved by auscultation of breath sounds bilaterally as well as sustained end-tidal CO2, assessing for the rise and fall of the chest, and mist in the endotracheal tube. Next, plan for the maintenance of anesthesia. This is achieved by administration of a volatile anesthetic agent, selection of appropriate ventilator modes and settings, and the assessment of total fresh gas flow. Finally, secure the endotracheal tube. First, we'll talk about positioning. Patient positioning is crucial for the induction of general anesthesia. Proper patient positioning, often referred to as the sniffing position, aligns the oral, pharyngeal, and tracheal axes. This provides improved visualization of the glottic opening and optimizes conditions for endotracheal intubation. After properly positioning the patient, apply monitors and obtain baseline vital signs. This includes 3 or 5 lead EKG, SpO2, blood pressure, and end-tidal CO2. The next step is to pre-oxygenate the patient. To review, room air consists of only around 21% oxygen and 78% nitrogen. By having the patient breathe 100% oxygen through a face mask, the lungs are filled with oxygen and therefore washes out the excess nitrogen. This can be achieved by either 8 vital capacity breaths or 3 minutes of normal breathing. Pre-oxygenation allows for a longer apneic period, allowing the patient to remain adequately oxygenated during the induction sequence, even if the patient has been rendered apneic. Next, we will begin administering our drugs. First, we will administer drugs to blunt the sympathetic nervous system response to laryngoscopy and intubation. This is typically achieved through the administration of a narcotic such as fentanyl and lidocaine, a local anesthetic. These drugs may attenuate the increases in both heart rate and blood pressure associated with sympathetic nervous system stimulation related to laryngoscopy and intubation. The next step is to render the patient unconscious. This is achieved through the administration of an IV anesthetic agent such as propofol. Under some circumstances, ketamine or etomidate may be appropriate depending on the situation or patient condition. However, propofol remains the most commonly used IV anesthetic agent. Finally, we will administer a drug to provide muscle relaxation. This is achieved by administering a paralytic agent. There are two types of neuromuscular blocking agents: a depolarizing neuromuscular blocker, such as succinylcholine, and non-depolarizing neuromuscular blockers, such as rocuronium. Regardless of the drug chosen, the end goal remains the same: to provide adequate muscle relaxation to facilitate endotracheal intubation. Following endotracheal intubation, maintenance of anesthesia is essential. This is achieved through the administration of a volatile anesthetic agent. Next, to provide adequate minute ventilation, appropriate ventilator settings must be chosen. A variety of ventilator modes are available depending on patient conditions, and tidal volumes are delivered at roughly 6 to 8 milliliters per kilogram of ideal body weight. So, to review, first, you will position the patient appropriately. Next, apply monitors. Next, obtain baseline vital signs, including blood pressure, SpO2, EKG, and end-tidal CO2. You will now pre-oxygenate the patient with 100% FiO2 delivered through a face mask. Now you will deliver the pharmacologic agents. First, agents to blunt the sympathetic nervous system response, such as fentanyl and lidocaine. Next, you'll administer drugs to render the patient unconscious, such as propofol. Following the administration of propofol, you will assess the level of consciousness and the patient's lid reflex, tape the eyes to prevent corneal abrasion, and attempt to mask ventilate the patient. Next, you will deliver an agent to facilitate endotracheal intubation. This is your paralytic, such as rocuronium or succinylcholine. Next, you will mask ventilate the patient until the onset of the paralytic drug. Next, placement of an endotracheal tube via laryngoscopy. After placement of the endotracheal tube, you will verify endotracheal tube placement. After placement has been confirmed, plan for the maintenance of anesthesia through the administration of a volatile agent, appropriate ventilator settings, and assessment of fresh gas flows. Finally, secure the endotracheal tube. This concludes our brief presentation on our Capstone project, which is studying simulation training in student nurse anesthetists. We thank you for your time and participation, and we look forward to working with you soon. Thank you.